aunque vamos a ir bien de tiempo porque en el programa el doctor Carballido le ha sido imposible venir, está muy alto, porque estaba con gripe y ha excusado esta misma mañana que no podía venir. Entonces andamos por eso un poquito con un poco de tiempo de relajo ahora, ¿no? Bueno, con la idea de hacer ya la tercera reunión que hacemos en el grupo de Urología Clínica del manejo individualizado y el tratamiento individualizado del paciente con cáncer de próstata, pues como digo, hacemos esta tercera reunión con la idea de tener un grupo de amigos que la verdad es que cada vez que nos ponemos en contacto con ellos siempre nos responden y aceptan gustosos el venir a Bilbao. Y la idea es tener no un gran simposium, sino un grupo de amigos que nos dediquemos un poco a hablar de los temas que nos preocupan, como decía antes, pues que es el cáncer de próstata y cómo empezar el enfoque de estos pacientes, cómo diagnosticarlos y tratarlos de la mejor forma posible siempre que se trata de un tumor localizado. Entonces, lo único, pues daros las gracias a todos. Tengo que dar las gracias también a todas las compañías que nos han ayudado en que esta reunión sea posible, aunque sea... El año pasado fue de una mañana de viernes, acabamos saturados y tarde, con lo cual este año hemos organizado para que sea de una mañana y una tarde, y a veces cuando hacíamos el programa pues nos quedábamos cortos porque es que todavía había muchas cosas para meter, ¿no? Yo creo que la mayor parte de los tópicos que nos interesan están incluidos, es posible que algunos se nos haya quedado en el tintero, pero, como decía, gracias también a las compañías que nos han permitido poder estar todos juntos y a la clínica también que nos ha apoyado en este salón en el cual estamos disfrutando. Y también yo el año pasado lo dije y este año lo vuelvo a repetir, tengo que dar las gracias a Congresos 21 y aunque no están aquí ellas ahora, pues a Carmen, a María, a Ainhoa y a Berta, porque realmente durante unos meses hablamos un montón, pero la última semana justo cuando vamos a hacer la reunión casi no hablamos, ¿vale? Y entonces lo único que quiere decir eso es que no hay problemas, que lo tienen todo organizado, se han puesto en contacto con todos, han concertado todos los viajes, han hablado con todo el mundo y entonces a mí me trasladan la mínima preocupación en ese sentido. Como ya me ha pasado un par de veces, pues estoy encantado de que sigamos colaborando siempre con ellas. Y sin más, voy a dar paso al doctor Nicolás Guerra. Nicolás Guerra es el gerente de la clínica y pues nos va a decir unas palabras para abrir un poco la reunión.
Bueno, buenas tardes a todos. Bienvenidos a Bilbao, bienvenidos al País Vasco, a todos los que sois de fuera. Yo creo que tenéis unas jornadas típicas en cuanto a la climatología y espero que en estos 2 días pues disfrutéis de vuestra estancia aquí, de la hospitalidad de su gente y de la cultura al final, que yo creo que es otro motivo al final de disfrute, además de lo que vais a disfrutar en estas jornadas, que la verdad es que cuando me dijo Ander que iba a preparar las terceras jornadas, pues pensé que era una jornada pues con un ámbito más reducido, como él dice, hablando de algunos tópicos, pero la verdad es que creo que no os habéis dejado nada en el programa. La clínica del igualatorio es una clínica que lleva 3 años desde su puesta en funcionamiento. Pertenece a la principal aseguradora del País Vasco, que es el igualatorio. Tiene 171 camas. La verdad que tiene una oferta asistencial completa, excepto el tema de trasplante de órgano sólido, grandes quemados. Tenemos toda la cartera, toda la oferta asistencial. Yo creo que es un gran centro sanitario. Pretendemos ser un referente en la sanidad privada del norte de España. Y la verdad es que, pues con equipos como el de Urología Clínica, la verdad es que yo creo que seguro que vamos a llegar a buen puerto. Llevan muchos años, de alguna forma, identificándose con los valores del centro. Yo creo que en cuanto a la incorporación de la docencia, la investigación, yo creo que lo tienen. Es un equipo muy cohesionado, que lo tienen bien divididos sus funciones, siempre están alerta a lo que hay. orientados, en principio, dentro de los valores que tiene la clínica, de orientación al usuario, orientación a resultados, pues yo espero que en esta jornada, de alguna forma, pues podamos ver si ahí andamos con el PSA, que yo veía aquí motivos para asistir a Bilbao. El PSA no es un marcador, cuando siempre los que estamos desde fuera vamos a las consultas de urología, lo que tenemos es el tema del PSA. Y luego, bueno, pues espero, la verdad es que no puedo estar en estas primeras reuniones, pero luego asistiré con gusto y a ver con qué respuesta salgo, ¿no? Yo creo que también estamos, bueno, con el desarrollo aquí en Clínica también, ese tema de la biopsia, entre incorporar la resonancia con la eco. Hay por ahí estudios que estamos haciendo con el tema de la biopsia líquida, que no sé exactamente con el tema de próstata aquí, no va, pero tenemos en otras líneas. Yo creo que hoy hablar de una jornada donde, bueno, es la mayor incidencia del cáncer de próstata, el primero en cuanto al sexo masculino es el próstata y el segundo en cuanto a ambos sexos. La verdad que es que espero que os resulte atractiva, que disfrutéis de la jornada y que seáis capaces de aclararos vosotros primeros en este mare magnum que hay, para luego dar esa tranquilidad a los usuarios y que de alguna forma salgamos todos más tranquilos y con las mejores perspectivas de tratamiento. Oye, felicitaros por la jornada que habéis puesto y que disfrutéis de ella.
Vale, gracias, Nicolás. Bueno. Bien, pues venga. Déjame un programa. Bueno, Pilar. Bueno, pues vamos a pasar ya a la primera parte. Yo, como decía antes, espera que venga Pilar, pero... Sí, no faltaría más. Hombre, aquí. Como decía antes, bueno, yo las jornadas estas siempre nos las hemos planteado con una idea, y es ¿qué pasa cuando un paciente viene a la consulta con un PSA? ¿Vale? Y entonces, en función de ese PSA que me trae, yo tengo que decidir qué es lo que hago. El año pasado o el anterior, pues saqué una imagen, hoy no tengo ninguna, yo saqué una imagen pues que salía un señor con un turbante diciendo que era un descifrador de PSA, ¿no? O sea, porque al final, a ver, ¿es importante o no es importante? ¿Qué hago? Bueno, la verdad es que en 2 años ha cambiado la imagen esa y vamos mejorando, ¿no?, la idea. Entonces, luego ya cuando decido si le tengo que hacer una biopsia o si es importante el PSA, pues digo, bueno, pues y ahora le tengo que hacer una biopsia. ¿Y en qué vaso hacer esa biopsia? ¿Vale? Y entonces, ya que tengo que decidir qué biopsia hago, a ver qué método tengo para hacerla bien. Y ya si además la hago bien, a ver el patólogo qué me dice con lo que me tengo que informar. Y con todo eso tenemos que hacer un juego mental para decidir qué tratamiento le vamos a decir al paciente. Entonces, bueno, pues al final lo que tanto con las reuniones estas lo intentamos es contestarnos estas cosas, en estas preguntas que las tenemos todos, pues bueno, lo que podamos aprender de unos y otros. Y por eso, pues bueno, como decía, en la primera vamos a estar con el diagnóstico, ¿no? El diagnóstico, a Joaquín Carballido le tenemos que excusar, como he dicho antes, porque no puede venir, por eso estamos un poco más relajados tiempo. Pero
es una pena, porque es un presentador excepcional.
Me ha pasado la presentación, pero no he tenido ni tiempo de verla en la mañana, pero era sobre diagnóstico y sobre tratamiento, que podemos hablar un poco de todos los temas anteriores. Y luego, pues vamos a tener tiempo como para poder discutirlo, que yo creo que es lo interesante, ¿no? Entonces, ¿le presentas tú a Máximo?
Bueno, pues sí, yo creo que está aquí ya preparado. Yo creo que todos vosotros sabéis quién es Massimo Valerio. Massimo trabaja ahora en Suiza. Felicidades. Pero es conocido por todo el trabajo que hizo con el grupo del University College of London y especialmente como un gran colaborador de Mark Emberton. Es el autor de varias revisiones sistemáticas Y después podemos comentar sobre todo esto y Massimo nos va a hablar del futuro del diagnóstico en el cáncer de próstata. Biomarcadores, con lo cual estamos trabajando en biomarcadores, la comunidad por los últimos 25 años y luego hablamos de lo que opina cada uno de vosotros en la sala. Entonces, biomarcadores, biopsias, los dos juntos o ninguno de ellos. Nos vas a decir que la Emery, que no hace falta biopsia. Me suena conocido en Holanda eso.
Bueno, gracias para la presentación. Estoy encantado de estar aquí esta tarde y para 2 días. Parece un congreso increíble y de verdad es un honor para mí estar aquí. Bueno, estas serán mis últimas palabras en español porque mi español no es muy bueno, pero voy a seguir en inglés. So I've been asked to talk about biomarkers biopsies, both are known in the future of the diagnosis of prostate cancer. So this is the plan of my presentation. The first is where we are today. I mean, I think in this kind of meeting, looking at people who are here, we are not in where the guidelines are, but this is the pathway the guidelines is recommending. And then the second point will be the criticism and why we need to look at other ways to do better for our patients. And then how we can use our biomarkers and biopsy to do better to our patients. So if we look at guidelines, you have a first step in which you have a PSA and a digital rectal examination. So when your patient is coming, he got his PSA, this is the first time you see him. And then if the PSA is elevated for your threshold, which is different in every center almost, you will consult for a biopsy. And then according to the cancer or no cancer, the patient is going to have other things. So if he has no cancer, you might do an MRI, or you can go back to the PSA and follow him in a few months. If he has cancer, again, you might do an MRI because you want to look at his risk according to this patient. And then you can choose for himself a kind of radical surgery or radical radiotherapy or active surveillance, or you can say your life expectancy is so short that you should be just watched. Now, if we look at the pathway, there are the two steps. The first one is the screening, which can be a formal screening, or which can be opportunistic in a way you do a PSA when you have a symptom or when you think the patient is at risk. And the second step is the diagnosis. So you have a marker, and then you decide you need sampling. So the question is how we can do better in each of these steps, and how biomarkers and biopsy can be better. So always you say if you want to find a solution, you need to find a problem. The first problem is this one. So this is the kind of advertisement you could get in the US a few years ago, in which you are on the street and you see 1 man out of 6 will get prostate cancer. You're free of charge. You can come to my office and you have a free PSA. So patients will say, this is amazing. It's free of charge. It can save my life. And in addition, this is very frequent. What are the problems of this? The problem of this is that according to from which method you use, the overdiagnosis is up to 67%. So it means these are men who will never had a clinically relevant disease, but they are still diagnosed with cancer within their lifetime. 67% is the worst figure, but still it's there. So the first thing we need to be better is to decrease the overdiagnosis rate. The second one is that the harms outweigh the benefit. So these are the 3 publications coming from the ERSPC. And you can see that as long as you move forward with the follow-up, from 9 to 13 years, the number needed to screen in and the number needed to treat to save 1 man decrease. But for those men who will live for less than 10 years, or for those who had other comorbidities, the harms largely outweigh the benefit because you need to screen at the beginning 140 men to find 1 man in which you can save 1 life. You need to treat 48 men to save 1 life. So 47, no benefit. So how we can do better? So again, this is about screening. There are two ways. The first one is to use PSA in another way, and the second one is to use novel biomarkers. If you want to use PSA in another way, this is one of the ways in which you can use your PSA. Instead of doing a PSA every year, or every 2 years, you can use a PSA between the age of 40 and 55, just one measure. And you can look at this graphic, which is amazing. If we think at how we criticize PSA, this is just one measure of PSA at 0 time point. And this is the risk of metastasis according to the percentile. So the guys who are in the 10th percentile have a high rate of metastasis, whereas those who are in the lowest percentile have almost no chances. So one way to decrease the overdiagnosis and to make benefits for more patients will be to use PSA at the beginning, and then to continue to use PSA only in those who are at risk, and to avoid to use PSA anymore in the others. So you can use PSA as a trigger. The second one is that instead of using PSA in all comers, all the population regardless of risk, you can use PSA in those men who are more at risk. So there's a lot of speaking about Afro-Americans or race, but this is a very nice study in which they look at the patients who carry the mutation of the BRCA1 and 2 genes, and they look at the risk following a normal pathway. So just looking at the benefit for these men against a control population. So when you look at the results, the positive predictive value was doubled in men who had a mutation of the BRCA. And even better, the only patients who had high-risk disease and were young, so which are those men who really benefit from the test, were those who had the mutation. So no man with no mutation had significant disease before 50 years. So this is another way. It is screening, so using PSA, yes, but using only in target population which are more at risk. Now, biomarkers, as Dr. Laguna said, we'll be talking about biomarkers. Everyone loves biomarkers. And so we will talk for all the future biomarkers. But this is a nice one from the Finnish arm of the ERSPC, in which they look at the frequent polygenic mutation in the population, and they look at the, again, target population using a genetic test. What they found is that prostate cancer in 74% occurred in those men who were at risk. So this is, again, if you can find at the beginning those men who are at risk, you can better trigger your biopsies. More importantly, if we think back to the criticism, is that you can lower your overdiagnosis of 21% using the same pathway, the same thing, same biopsy, same PSA, but you just target this man. And you will reduce your overdiagnosis by 21%, which is huge. So you can use the polygenic risk score as a triage test, again, another way to do things and to better your screening. This is a very, very elegant study done in Stockholm. It's very interesting because this is funded by the council. And so they look at their data in Stockholm and they said, this is, so many men are getting biopsies, so many PSA die in Stockholm, there is no effectiveness in all we are doing. And so the council funded them to doing a novel test. This is a biomarker, but it's a combination of markers. So you got known proteins, so like PSA and other kallikreins. You have 254 SNPs, so genetic test, and you have clinical parameters like age, digital rectal examination finding, biopsy, and family. I need to say, they didn't disclose how, from a statistical point of view, it works. So you don't know whether you have an iPSA and a mutation in the SNPs, how you can balance these things. But the results are, again, amazing. So when you look at the two populations, so those who were at risk and those who were not at risk, so the overall results looks like this. So if you use the test, the triage test, you will decrease the number of men diagnosed with low-risk disease by 70%. You will decrease the number of men who will have a biopsy but will get just no disease by 44%, so almost 1 out of 2. And overall, 1 man out of 3 could avoid biopsy according to this test. Obviously, this is done in the first period, so we don't have long-term data, but still, it's a huge difference. So when I prepared my slides, I didn't see there was another speaker talking about this. I will not go through this, but you will hear about this in one of the next presentations. So this is for screening. When you get to the sampling, you can do even better probably, and there is huge evidence. So what's the shortcomings? What we need to do to be better than now? So if you take random biopsy, the problem is that you're missing your spatial location. You can rather say it's right or left, but nothing more than that. You don't have any information about local extension. Your correct resource distribution is only in 50% of the cases. And this is a good figure because it's compared with those men who undergo surgery. And you cannot follow progression because you have a random sampling. So your chances to get back to that is very low. So how you can do it better? Dr. Laguna said before, but if you use an MRI before, so this is not done by myself, but this is a systematic review of the performance of the MRI. So all series comparing MRI to biopsy. And when you look at the results, it's actually not perfect. When you look at the precision, so the accuracy, it's not perfect at all. You can see that there are values at 33%, some 50%, 44, 72, 82. So this is the number, the true positive plus the true negatives against all the cohort of men. It's not perfect. So you can choose a lone MRI. But there are some parameters which are very good. So the first one is the sensitivity. So when you go to sensitivity, so how many you can detect using only MRI, you can see it's very, very high. And you can see there is one series which is low, but all the others are almost over 90%. And this is all serious. There is no selection of X% or so whatever. So sensitivity is very good. And the other thing which is very good is the negative predictive value. There is again one series which is not very good, 63%, but almost all of the others are around 90% and over. This is only for the detection of clinically significant disease, which is what we are looking for. So I think MRI could use as a second trigger after a biomarker. And then if it's negative, it's up to you whether you want to propose some sampling to the patient. And if it's positive, then you need to sample this patient. So when you go to sampling, you can do this in different ways. But something very fashion today is to use the software to do the MRI and transrectal ultrasound fusion. You need to contour your prostate on software. This is an old video, and I had to do this myself. So you have to contour the prostate and the lesion on every slide. And then your software will give you a 3D model in which you will see your prostate, but you will mainly see your lesion, and then you can target your lesions using this software. Now, what's the evidence? In this systematic review, we look at all series comparing standard biopsy to fusion-based targeted biopsy using a software. The first outcome was the detection of clinically significant disease. The second one was detection of any cancer, the efficiency and the utility of the two strategies. So there were 14 papers reporting on 15 studies. You don't have to go through these slides, but I would just want to show you that obviously there's a lot of heterogeneity in these systematic reviews. The population is different. You have men who have the first biopsy, those who have a previous negative biopsy, and the number who have a mixed population. Also, it's different the kind of MRI you have. So you have 1.5, you have different sequences. But most importantly, it's different the threshold for targeting. In the first series, almost any man was targeted. And now we are looking at which is the threshold between 3 and 4. So this is the primary outcome, and this is the results. So the detection of clinically significant disease for the targeted approach was at 33%, against 23% for the standard biopsy. But most importantly, if you look at every study, and you look at the absolute difference in all series, there was an advantage for the targeted approach. If it was not the same, there will be in the range a minus somewhere. But you can see that the range is always positive between 1 and 41%. So primary outcome, always better the targeted approach. When you go to the secondary ones, you get the detection of any cancer, so not only the clinically significant ones, but any one. You can see the difference is not so huge, and you get to the absolute difference, you get that there are some in which the standard biopsy perform better. What is huge is the efficiency, so how many needles you need to find one man with clinically significant disease. So for the targeted approach, you need 9 needles. For the standard one, you need 37. Again, the absolute difference is usually in favor of the targeted approach. This is the very important outcome, which is the utility. So this means the number of men will be missed by one strategy and detected by the other one. So when you look at the targeted, the utility of performing the targeted was important. So almost 1 man out of 10, and ranging between 5 and 60%. The utility of doing a standard biopsy was quite low, at only 2% of a median, and importantly, between 0 and 7%. This is for standard biopsy. When we did the systematic review, there was not this study which came afterwards. This is the NIH group recruiting over 1,000 patients, all comers again, just they had a suspicion of disease. This is the kind of patients I think all of us see in our clinics. So 62 years old, a median PSA at 6.7. So when you look at the results, this is amazing. So the sensitivity of the targeted approach against the standard approach was 77 against 53%. More importantly, in order to find 1 man missed by a targeted approach, having significant disease, you will need to biopsy 200 men. So in 199 men, there is no advantage in doing a standard biopsy in addition to a targeted one. When you find 1 man with significant disease, the problem you will find 17 who had, again, low-risk disease. And if we look at the first slide and we see we are coming from decreasing the overdiagnosis rate, then this is not a good ratio. This is, again, quite impressive because this is the accuracy and the performance of the test compared one against the other. So this one is the targeted approach alone, this one is the standard approach alone, and this one is combined. So any of us thinks if you get 2 tests together, they are better than 1 test. And actually, when you look at the sensitivity, the combined approach is the best one. When you look at the negative predictive value, the combined approach is the best one. But when you look to the accuracy, so again, true positive plus true negative, the best test is the targeted approach alone. And why is this? Because you get so many men who are suspected to have high-risk disease, and in fact they don't. So according to the accuracy, and if accuracy is your best value, you should perform only targeted. So this is my last slide. I think the future is here for most things. We can do much better today. The guidelines are always in late with the practice, but we can do a number of things. The first one, we could use a PSA at the beginning, but just repeating those who are really at risk. We could use PSA in targeted population. Are there novel triage tests? I think we are not ready. The Stockholm test, the Stockholm trial will get new results in 1 or 2 years. And I think we are ready for imaging and targeted sampling. Thank you.
Bueno, yo creo que igual lo que hacemos es dejar para el final las preguntas, porque, bueno, si hay alguna pregunta de la sala que le queráis hacer a Mario. Ha dicho muchas cosas interesantes, pero yo creo que igual lo dejamos para el final, que así mezclamos un poco todo y estamos... Bueno, la siguiente conferencia, la siguiente charla, nos pusimos en contacto con el equipo de Heidelberg y entonces Philipp Radke aceptó la invitación para venir porque su grupo también es un grupo que está trabajando mucho en cómo hacer las biopsias de distinta forma. La verdad es que aunque está un poco adelantado en el programa, es por un problema de horario de avión que tenía que marchar pronto a la tarde, y entonces es el motivo por el que lo hayamos incluido aquí, pero nos parecía que era muy interesante lo que nos tenía que decir, y sobre todo agradecerle, ahora que nos lo va a escuchar, espero, agradecerle el haber venido, pues a que ha llegado al mediodía y que se marcha a media tarde de vuelta a casa, ¿no? Entonces nos va a hablar de la detección del cáncer de próstata, que es el que nos interesa, el clínicamente significativo, y utilizando lo que nos ha comentado Máximo ya de la resonancia fusionada con ecografía.
Okay, good afternoon, and thank you. And it's been an honor to be here and to speak to this audience who are experts in the field of at least not only biopsy but also of biomarkers. And this is quite interesting just for us and for our group and for me in particular to be part of this. So thank you very much. What our idea is, this is the current standard. The current standard is within diagnosis of prostate cancer. There is the TRUS biopsy in the center of diagnosis. And what I want you to show is how we can bring the MRI and the MRI TRUS fusion biopsy from the peripheral to the center of the biopsy and the biopsy approaches. And for that, we have to answer 4 teaching points. The first is problems of conventional 12-core TRUS biopsy, as Massimo Valerio told before. Second one is MRI and TRUS fusion guided biopsy, what it is and what we have to know about. The third one is compare this to the standard approach of 12-core TRUS. And the fourth is what are the pitfalls of this. So starting with the problems, and this is what we all know, that 40 to 50% of biopsies taken by the 12-core TRUS approach detect low-risk prostate cancers that won't affect and won't threat the patient's life for over at least 15 to 20 years. And the second one is thank you. And the second one is upgrading Gleason score compared to radical prostatectomy from biopsy in 35 to 65%, and low detection rates around maximally 40%. And this means that up to 80% of significant cancers and 90% of bilateral tumors are missed by the transrectal approach. So the second one is underdiagnosis of aggressive disease. And putting this together, and this is why, and as Massimo Valerio told before, also from the group of London, this is why we miss those cancers, because the biopsy needle in the TRUS approach is too short. It's around 1.7 centimeters, and this is why we miss apically and anterior located prostate cancers. And we miss a second, and this is important. So these are data from Sweden, with around 50,000 men underwent biopsy, 6% urinary tract infections, and 1% hospitalization. And there are also some death among this TRUS biopsy. And what is also increasing is the resistance of fluoroquinolones regularly given against Escherichia coli, and which is very important is initial prebiotic resistance in 24% of patients. So what do we do? It's an aggressive and it's mostly a cost-increasing approach. There's a transperineal biopsy approach. We do it in Heidelberg. So this occurs less infection of 0.1%, and it causes, in some cases, urinary retention, okay, and hematuria. What do we need to perform for a fusion? Of course, we need first an MRI. And this is a picture of what we're doing. We first perform the MRI and then fuse a live truss over this MRI and plan this digitally, and then just perform both. On the one hand, saturation biopsy. However, you can do a saturation or you can do a 12-core biopsy as a systematic part of a fusion biopsy. And on the other hand, perform targeted cores who are done in these areas where the MRI is positive. So which are the advantages of this approach is, okay, first you can document where you took the biopsy. This is important for radical prostatectomy, but also for focal treatment. And what we saw is that doing and performing this MRI transfusion, we saw that we are very accurate and very exact of around 2 millimeters correct for where we did the biopsy, where we planned it. And what you can do here, and what you can see is, okay, you just performed the biopsy where you planned it digitally, and then you can see, okay, where I have to go to target the core, and then you perform it. And then you can measure, okay, how good I am or even how bad. What do we need for this MRI? So-called multiparametric, and this is just a combination of morphologic and functional MRI. And we start with morphology and just perform a T2 weighted imaging, followed by contrast, by a perfusion, and the contrast is so-called DCE, and you measure just arterial input function, and then you measure a curve, a contrast curve. The third, it's a little bit historically, at the moment is this metabolism measurement of choline and citrate peaks, and the fourth is the new kid on the block is the cell density measured by diffusion-weighted imaging. And this is very important because I will go later back to this, because this allows you to, in a way, predict Gleason scoring in a way. And the good news are, when you perform an MRI, leave the metabolism away because it's not easy to adopt, and it's much, much better for your radiologists, and the perfusion is also questioned. So what you need is basically T2 weighted and diffusion weighted imaging. What you do then, you do structured reporting on a 5-point Likert score from 1 point probably benign to 5 points probably malignant or highly probably malignant, and that you do for every lesion and for every sequence. So as you can see here, you have T2 weighted imaging, you have DWI, and you have contrast agent. And as you can see here, 2 lesions, one in the anterior part of the prostate and one in the peripheral zone and the dorsal part. And as you can see in the T2, okay, you can see here the lesion. Then you perform diffusion-weighted imaging. You can see here and here in the ADC mapping that is very, very dark, so it's also 5 points. And then you perform the contrast examination, and then you can see, oh, okay, here I see a fast input and an outwash, so it's again a 5. And then you perform an overall pirate score, and the overall pirate score per lesion is in this fact a 5. Does this work? Yes, it does. First, data from external validation with an area under the curve of 0.84. Very nice results published in 2012. And also from our group, did the same 1 year later, and also had for the Likert score a very nice and accurate area under the curve of 0.88. This was cumulated in a meta-analysis from the colleagues of Nijmegen in 2013, including 14 studies. And here you can see as well a cumulated area under the curve of 0.82. So meaning pirate score works. And it does not only work, it can also predict, and it can also predict significant cancers. As you can see here, for a pirate score of 4, as we remember, is looks like that it is a malignant lesion. Okay, you can see here a positive predictive value of 68%, and for a pirate's score of 5, a positive predictive value of over 80%. So these are very encouraging results. Then, this is when you implement a new test, you always have to compare it to the standard. And the standard is, of course, still 12 contrast biopsy. And here are results from a group of Norway and together with a group of Los Angeles. and they did a one-to-one allocation of MRI transfusion biopsy compared to a standard biopsy approach, and seen completely the same groups. And what they saw is, first, clinical significant prostate cancers detected by targeted biopsies were significant, and as you can see here, significant more clinical significant prostate cancers were detected by this fusion approach. And on the other hand, only 5% of those clinical significant cancers were missed by the targeted approach, and in addition, 11% by the MRI alone. And what are the cancers that missed? These are in fact mostly Gleason 3+3 and also clinical not significant cancers. So also getting in a way that the MRI transfusion is very, very efficient. Group from NIH, as Massimo Valerio told before, this was the prior very interesting paper of them looking at repeat biopsy patients and detecting that multiparametric MRI and the transfusion on top misses only 7% of significant cancers, but did not detect 36% of those clinical not significant cancers we might not want to see. And this is also good for the Likert score, is that per Likert score that increases, you have a 2.5-fold probability of significant cancer. And this going short through this because we had this results before. Just one sentence on that. Targeting biopsy diagnosed 30% more high-risk cancers compared to 17% fewer low-risk tumors when the transfusion approach is compared to the standard 12-core approach. So very interesting, and this slide is nearly the same, but it is so impressive that we have to repeat it. The number needed to biopsy in addition of a performed targeted biopsy is extremely high. So you have one high-risk cancer, you need 200 biopsies, and this is also more impressive in my eyes. To detect one high-risk PC more, you detect, on the other hand, 17 low-risk cancers. What did we do in Heidelberg? We compared this to a saturation, a transperineal saturation biopsy, and we found nearly the same. We found that MRI-targeted biopsies detect 46% of clinical significant cancers compared to 8% in addition of the saturation approach. And this is also in discussion how many cores you need. You need 3 targeted cores and 7 systematic biopsies to detect one clinical significant cancer, and this is also an advantage of the MRI transfusion approach. Just 2 short slides on fusion platforms. If you are interested in those fusion platforms, you need to compare rigid fusion and elastic fusion. The advantage of elastic fusion is that after every biopsy you take, it is the fusion will get back to the prostate form you had before the biopsy, and this is not the same with the rigid fusion system. With the rigid fusion system, you have to think about, and you always have to renew your fusion, and it doesn't do it for itself. Does this has an impact? And some studies, yes, it has. Here, comparing elastic fusion to rigid fusion, detecting that the elastic fusion approach detects more significant cancers compared to the rigid one, and also compared to cognitive fusion. These data suggest, okay, throw our cognitive fusion away and just always buy an elastic fusion system. Not really. Published last year, 2015, by Panebianco et al. Also interesting data and supporting the guys who perform cognitive biopsies. Here you can see, okay, what did they do? They performed MRI and targeted biopsies, and if negative, they performed saturation afterwards. And as you can see here in this group B, they detected 410 patients with significant prostate cancer and only 9 addition cancers on the rebiopsy. So meaning that there is a high sensitivity of 86% and a high accuracy of 97% for a cognitive fusion approach. What did we do? We wanted to know, okay, how good are our targeted parts and the saturation part of our fusion biopsy? And we compared it to radical prostatectomy specimen. And we also took the MRI for alone and looked, okay, how many index lesions, meaning that it is the tumor-driven lesion of the prostate or within the prostate, are detected by the different approaches. And what you can see, we start with the combination. So perform saturation or systematic biopsies and perform targeted course together, detected 96% of these index lesions correctly compared to radical prostatectomy specimen. And what you also can see is that the targeted part alone only detects 80% of them. So meaning, okay, there's still a problem, and this is a problem we have to solve. So why do we miss, compared to the MRI, 12% of cancers? And this is, in fact, as you know, okay, 80 is good and 92 is much, much better. However, this was statistically significant. As you can see, okay, fusion targeted biopsies alone are inferior to the combination of those. And in case of detection of an index lesion or of significant cancers, we have to do and we have to favor both the combination of saturation and of the targeted course together. So having an aggressive approach, but also doing then and looking at and see 96% of index lesions. So what can we see and looking at this cohort, we can see, okay, we correctly identify by MRI 92% of all index lesions. And looking not only at index lesions, but at significant cancers, we have 84%. But we see, okay, targeted cores alone are inferior to the combined approach. And that leads us to the fact that biopsy targeting is not perfect yet. Nearly similar results as a group from France detected 1 year before. So what about the transperineal approach, aggressive approach? Not very cost effective, but we can see, okay, this is as good as the MRI, but it missed some cancers and it increases adverse events and it increases the detection of insignificant prostate cancer. So what we can do now, we can stop the discussion and say, MRI transfusion targeted course is very good, use it. Not without talking about these pitfalls. And these pitfalls are important and we have to talk about them for a few slides. What is important and what we have to think about. And we have to think about, the first is an MRI problem, it's the underestimation of tumor volume. And as you can see here, nearly around all tumor volumes, you can see the tumor volume is underestimated around 10 to 30% compared to radical prostatectomy. And this is important not only for biopsy, but also for targeting your focal therapy, but not only for your focal therapy, but also for radical prostatectomy. And this group from New York suggested to perform a safety margin for therapy planning of around 9 millimeters and to enlarge your MRI lesion to get correctly identify the volume of this lesion. The second one is, how good is our radiologist? So it belongs to reader experience, as you can see here. In the peripheral zone, the inter-reader agreement is very good. However, in the transition zone of the prostate, it is not as good, because in the transition parts of the prostate, false positivity is a problem, because false positivity occurs when you see a benign lesion within the prostate, and you say, okay, this benign lesion is in a diffusion-weighted imaging, it's very dark and the diffusion is restricted. However, it's a benign nodule and not prostate cancer. And also in the transition zone, the problem is, what about DWI and DCE? As you can see here, it doesn't matter if you perform a contrast agent examination or not. And this is nearly here the same. When you perform a biparametric MRI, T2-weighted imaging plus DWI, you are as good as you perform a multiparametric one. So this is what we have to talk about. And the last problems are, what about these PIRATES 2 lesions, remembering probably benign? And if you're looking at nearly all publications, you have this false negative rate of 5 to 12%. What to think about this? Tell the patients, okay, you have not a significant prostate cancer, but the risk of having it is 5 to 12%. Perform a systematic biopsy in case of that, or related to clinical probabilities, and just look, okay, has the patient the risk of cancer or even not? And it's nearly the same with Pirate 3 lesions. There is variable tumor detection, as you can see, between 10 to 70%. It belongs on which publication you read. And what we have to do with this, biopsy every patient and having the risk of 90% negative biopsies. And what about the ADC on the MRI? And what about ESBC risk calculation and clinical parameters? Do we have to put them together with the MRI result to get a valuable prediction and not having this range of 10 to 70%? The answer, in our opinion, is clear here, because the cutoff is very nice and the risk is minimally 10%, so biopsy it, right? So this is very important. And last issues, multifocality. We know that if there is a solitary tumor lesion within the prostate, we'll find it. However, in case of multifocality, we'll miss more tumors. And characterization of aggressiveness, and this is what we need to discuss with our radiologists, is, okay, this importance of the diffusion-weighted imaging, so as low the ADC value is, as high the probability of having high-risk prostate cancer is within this lesion. And this picture is very impressive. As you can see here, this dark lesion, you can see, okay, as dark and as low this ADC is, as you can measure it automatically. As dark this lesion is, as higher is the Gleason score you have. Okay. Just one look in the future. What can we do with MRI? We can not only measure this ADC, but also this ADC entropy, for example, or impressive data from Memorial Sloan Kettering, looking at 10 different MRI parameters that you won't see with the eye, but you can measure them. And what they think and what they do is compare this low-risk cancers compared to intermediate and high-risk cancers. And what they can defer this on MRI, and with a very nice accuracy. And this may be the future of MRI, not only looking at 2 or 3 multiparametric sequences. Okay, so in conclusion, looking very busy, but it will be solved quickly. 90% of the cancers we want to see, clinical significant ones, can be detected by MRI, and we do not see the cancers we probably won't want to see. MRI targeted biopsy alone has fewer and better biopsies. However, we miss some cancers, around 15%. Mapping remains the gold standard because we found nearly every cancer, with the costs of increasing costs and increasing side effects and probably over-detection. And I think we think you should individually go to your patient and tell him, okay, what do you want? Reduction of overdiagnosis, then perform targeting alone with the risk of 15% having cancer that is not detected, or you want maximum safety, then get the combination. And dealing with the problem of the targeted, we suggest to perform target saturation of this area in case of a positive MRI. So I hope we are getting this change and getting the MRI and the MRI transfusion in the middle of the prostate biopsy approach. Thank you.